Tim, you can finally record in your own Zoom room.
Yeah, we're not entirely sure what was going on with the other one.
Yeah, so he just sent us a new link.
I think Kyle hijacked it. He was trying to take over the lobby.
Okay, so how do I do this? Screen share. Can you guys see my screen?
We can.
Okay, great. Slideshow. Yeah?
Yep, Heme rapid fire review.
All right. So this is going to be pretty quick. Hopefully you guys can get maybe 3 factoids out of my portion. That's the goal. I usually set a goal. So no need to take notes. Everything is coming out of the compendium or the WHO if factoids need to be verified, or Henry's. All the amazing images come from the ASH Image Bank. So, okay. So I will give each question / slides like 3 to 10 seconds, and then I'm just going to move on. So can anybody ID the top left?
Hemoglobin C crystals.
Yeah. Okay, so what about the top right? So,
Somatocytes.
close. That's
hemoglobin crystals.
Yeah, they are hemoglobin crystals. So these are not the best examples, but I guess the boards will give you terrible examples. So they are called, I guess, like taco cells or whatnot, but hemoglobin SC. And then the bottom, I think Melissa already said it.
Somatocytes.
Yes, perfect. So mix and match. So what conditions or cells are associated with on the left? So target cells, do you guys know what it's associated with?
Thalassemia.
Yes, but something from the right side of the column.
Oh.
Very good, but yeah, something from the right. So it's actually associated with hemoglobin C. Stomatocytes, anybody know what it's associated with?
RH null.
Yes. And then bite cells?
G6PD.
Yes. Teardrop cells?
Myeloplastic changes.
Yes, extra points for pronouncing that. And then Heinz body.
I think also G6PD.
Yes, awesome. So another mix and match. So mix on the left to the right. So basophilic stippling, do you guys know what it's made out of?
Iron containing mitochondria.
That is a really good guess, but not for this one.
Okay. Ribosome?
Yes, it is. So Pappenheimer body is actually the one that is iron-containing mitochondria. Howell Jolly bodies, does anybody know what this is made out of?
I think it's
DNA remnant.
Perfect, yeah. And then Heinz body?
denatured hemoglobin.
Perfect. And then Cabot rings?
The remnants of the mitotic spindle, basically.
Yes, yes. So basically another nuclear DNA remnant, but yes. So which one is the one that's only seen with a supravital stain?
I think you have to use, I think it's it's either Pappenheimer or Howell Jolly bodies. No, neither of those. Okay, Heinz body?
Yes. So I remember it as Heinz ketchup is super vital. So that's how I remember it. Okay, so can you guys ID? What is the first stain, first of all?
Does not look like a usual Romanowski-based stain.
So this is what supravital stain looks like.
Okay.
This is Heinz body. So what is the one on the top right?
Right, Gimza?
Yeah, and what is the what is the inclusion?
It looks like a Howell Jolly body.
Yes, yes. Okay, so and then what is the one on the bottom left?
Basophilic stippling.
The stippling.
Yeah, perfect. And then the bottom. What was that?
the same process of elimination as this Pappenheimer body.
Yes. Okay. So then do you guys remember what these are made out of when you see these images? So starting from Heinz's body.
Hemoglobin, remnant of hemoglobin.
Yes, denatured hemoglobin, perfect. And then
Okay.
how Jolly body?
It's remnant of DNA.
Yes, awesome. Basophilic stippling?
Ribosomes.
Yes. And then Pappenheimer bodies?
Mitochondria.
Yes, with iron, perfect. All right, so this is what Kappa ring looks like if anybody was wondering what it looks like. Name the equation. So this is kind of annoying, and you probably guys don't need to know this until right before the boards, but hematocrit over RBC times 10. Anybody know what this is for? So like, what do we need to know in order to?
Is that MCV?
Yes, perfect. And then what is the next equation? Hemoglobin over RBC.
So it'd be the mean hemoglobin concentration, MHC.
Yes. And then the next one, hemoglobin over hematocrit instead of the RBC times 100.
MCHC.
Perfect. And then the last one,
Percent reticulum. The absolute retic.
so it's basically corrected reticulocyte count, so that's pretty close. And then when do you guys see a high MCHC? So mean core.
Iron deficiency.
It's a good thought.
I'm not sure though.
Oh, okay. Yeah, these are the 30 things that I saw on the compendium.
Okay, good to know.
So echinocyte and acanthocyte, so I'm just giving you guys like a basic overview of the differences. So one has a central pallor, one does not. One has evenly spaced projections, one does not, and has like this club-like projections, whereas the other one, the echinocyte, has short projections. Echinocyte is associated with uremia, so just think of kidneys, whereas the acanthocyte is liver. Acanthocyte also is notably associated with McLeod. So I hope you guys retain something. So which one is this? Equally spaced projections, echinocyte or acanthocyte?
Echinocyte?
Yeah, perfect. Which one is McLeod or associated with it?
McLeod's a acanthocyte.
Perfect. What about A beta lipoproteinemia?
I think also echinocyte.
Yeah, I think so.
Maybe acanthocyte then, if it's not
Yes. Yeah, so I just remember this as like liver associated, and then echinocyte is more like uremia, and I guess, yeah. I don't know.
A beta, A acanthocyte, sure.
Yeah, there you go. And then EDT artifact?
Wasn't aware of that being associated with an abnormal red cell morphology, so I'm just going to say echinocyte because they're common.
Perfect. And then which one was this picture?
That's hard. So I guess the way I remember acanthocyte versus echinocyte, acanthocytes you have like much more exaggerated projections, and I feel like you less often see central pallor. I kind of want to call this an acanthocyte.
That's melanocyte.
Not.
Well, I actually used the same image on the last slide. But yeah, this one was based on the CAP image. This is acanthocyte. And so acanthocyte, I guess going back to the slide, no central pallor is, I guess, with acanthocyte. And then echinocyte is central pallor. But yeah, that's how I learned it from Ash Image Bank. Okay, moving on. So folate versus vitamin B12 deficiency. So I'm kind of stepping into the chemistry. I'm straddling between the two. But which one has accumulation of MMA? And it could be both. It could be not.
Vitamin B12?
Yes.
B12, if not both.
No, it's not both.
Yeah. What about, which one is absorbed at jejunum? So which one's absorbed first in the gut?
I think it's B12, and then it's folate.
Folate.
This is like the
Yeah, it's actually other way. So it's folate first and then B12. Which one is associated with dilatin? So phenytoin.
Totally no idea.
B12.
Folate?
Yes, yeah, good job, good job. And then, so what medication is classically associated with folate deficiency?
Methotrexate.
Perfect, yeah, perfect. And then increased urinary FIGLU. I did not even, I've never heard of this until I saw it in the compendium, but I guess this is testable. So this is B12 deficiency, and then elevated
So,
homocysteine.
sorry, just a quick question about that one. So
Sure.
in all cases of B12 deficiency, whether due to diet or whatever else, this is like a consistent and reproducible factor or a lab finding, or is this associated with like a particular etiology of B12 deficiency?
That is something that I will have to look up and get back to you. Sorry. Elevated homocysteine.
Both.
B12.
So both. So, and then elevated MMA.
B12.
Yeah, exactly, because I asked it in the first question, right? So yeah, so homocysteine can be elevated in both, or you see it elevated in both, whereas MMA is only elevated in B12 deficiency. So I'll share the slides with you guys. So, and it's in the compendium, so you guys will see it there. So I talked to my friend last night, and according to this person, you will get a gel with control and no labels. So we will have to know the order of the labels. So what I learned in my residency was a fat Santa Claus, and it goes from positive to negative on all my mnemonics. So basically a fat Santa Claus, and then you see that there's all these mnemonics attached to S and A2. So I learned this as sad dog gets love and a second CEO. And then so that's for the acetate gel, which is the basic gel, and then the citrate agar gel, which is like the acidic pH, has a mnemonic of Caesar salad out, Asian food, and so O is actually the origin, so that's where you insert the specimen, and then it runs in either directions. Whereas cellulosic gel runs from negative to positive. Unfortunately, the mnemonic goes the other way, but oh well. So Caesar salad, out, and then Asian food is in. So that's how it goes from positive to negative. And then AD, so as for GORN, that's how I learned it. So like ads for National Geographic, Nat Geo. So this is probably something that you might get on your boards. No labels, maybe a plus and a negative, they're nice. So you're gonna have to kind of infer like from like the mnemonic. And so first you have to like kind of remember what it was. So a fat Santa Claus, so A, F, and then S, and then C. So looking at here, and then A was the one that was by itself. So you know that this is hemoglobin A. The second one had a bunch of stuff. Sad dog gets love. And then when you look at the second gel, it's Caesar salad out, Asian food. So this one is S, hemoglobin S. And then the second one has all these mnemonics. So you have to see what is common between the two gels. So the top one is hemoglobin A by itself. The second one is hemoglobin S by itself. So this one's kind of easy. It's a sickle cell trait, hemoglobin AS. Going on a harder example is the one that has a whole bunch of stuff attached to it. So we all know that a fat Santa Claus. So this has SDGL, sad dog gets love, is attached to this. And the second one is the second CEO. So it's more like it kind of reminds me of like blood bank and looking at like that little panel. You just have to like play logic and know what is common. So hemoglobin S kind of gives us a clue, so we can kind of infer that the top one is also a hemoglobin S. Boards are not going to be mean, so they're not going to be like, oh, this could actually be like triple things. You know, they're not going to be like that. So you can infer that the top one is actually hemoglobin S. And then the second one, the two common things are E and a O. So O is ORAB. So which one is more common, hemoglobin SE or hemoglobin SORAB? So SE is a little more common, so that's what it is hemoglobin SE. So you just have to play logic and memorize the mnemonic however you want to memorize it. So you're halfway there. I'm going to pass this off to Kyle. So thank you for your attention.
Thanks, Moe.
All right, hopefully you guys can hear me now.
How do I stop
I can
sharing?
hear you. Can you hear us?
Yeah, I can hear you guys now. I have no idea what happened before. That was kind of weird. Oops. Damn it. All right, this is going to be kind of rapid fire. It's all morphology. So you guys will be pretty good on all this. There's a few things I kind of left out, but we were going to maybe go through and add a few things over the weekend and maybe have this, you know, available in the M drive for people to kind of review, especially for like boards and stuff. So, all right.
Kyle, do you mean to share us the notes
You're in
section?
presenter mode.
Oh, wait, what the hell am I? Oh, I had it switched out before. Sorry. Let me end slideshow.
Just unclick and that. Oh,
No, it won't let me do it.
no,
If
so
you
if
go
you
to
go
display settings in the top left, that button there, click that.
Uh-huh. Oh, here we go. So you guys already have the first one. Excellent. But all right, so go ahead. Somebody describe this one really quick.
get
Our
some.
rods.
Packed with our rods, right? And that's the whole clue on this entity. So translocation is what?
15, 17.
Yep, 15. I think I heard 15, 17.
Game over.
And yeah. All right, so this is kind of a next level question. What is the common phenotype seen here? So just to kind of walk you guys through, this is for mainly people that have had some heme. So here's your blast population. Here, bright MPO, and we have good 1333. However, when you come here, you kind of have loss or weak 34 expression, weak 7 CD117, and weak HLA-DR. So this is the classic, and I think that this will likely be testable on boards. This is the classic phenotype that you see with APL. So we get flows concerning for this all the time. So this is something when you're on the heme rotation to really keep in mind, because review of a peripheral smear and then getting flow on it is something that comes up often, and the clinicians want to know with some certainty whether or not you believe it's APL or not, so they can give ATRA. Next question. No one probably knows this, but what are the variant RAR translocations that are resistant to ATRA? So this might be somewhat testable on the boards. And I'll just go through this one here. So the first one here, ZBTB16 is one, STAT5B, and this is also a very kind of unknown, kind of rare translocation that happens with an APL phenotype, and all three of these are resistant to ATRA. All right, so let's go. So to the first one on the left, what are the classic findings in this, and what's the translocation? You see one single hour rod here, right? And then you see salmon colored granules. So if you see a blast like this with a single long tapered hour rod and salmon colored granules, what translocation should you be considering?
Just
Is
9.
it 812?
821, right. And the reason why we go over these translocations is because I've come to find out that being on heme, it's very important to have morphology in mind, because karyotypes take a long time to turn around, probably over a week. However, if you think that you are looking at the aspirate smear and you see this morphology and you're like, wow, this I think this is 821, you can let the cytogenetics lab know upstairs, like Rachel Sears and Angela Lager, and let them know that, hey, we think that this morphology is fitting for this certain translocation. They can fish probe it and turn it around in 72 hours as opposed to, over a week. Sometimes even less than that, 48 hours. So it is very helpful, and it helps guide therapy for these patients. So the next one in the middle, what are you guys seeing?
Butterfly and coin on coin.
Right, coin on coin, right? So with this one, what are you not, even though you're seeing the coin on coin appearance, what is lacking in the cytoplasm?
No out rods.
Right, no outer rods, no granules. But given that, what's the translocation?
So still thinking about 1517, but is this the hypogranular variant?
Yes, exactly. All right, just saw one of these yesterday. So classically, you have blasts in the background, and then you kind of have these weird, kind of odd eosinophilic myelocytes that have these kind of purplish basophilic granules in them. So what translocation can you think of?
Or the core binding factor leukemias.
It is one of those.
Mm-hmm.
And this actually, based on the morphology that we saw in the peripheral smear, we told cytogenetics to fish for inversion 16, and they do it by using a break apart probe for CBFB, the core binding factor B, and it showed this. It showed it showed the translocation. So we were able to definitively call this type of AML in 72 hours, which was really fantastic.
So the reason they have to do fish is that it's too subtle for karyotyping, like it's too small of an inversion to be picked up on karyotypic studies.
Right, and sometimes you can get the I think there's a translocation too of 1616, so it's kind of difficult. But I mean, we still do karyotypes almost on all cases, but by doing the fish and having them, telling them specifically like, hey, fish for this target, it helps them a lot, because otherwise they're doing like an AML panel, right? And they're fishing for all these different targets. So it takes a little bit longer, but if you can definitively tell them based on morphology that you think it's such and such, they can able to turn it around much faster. So it does help. Moving on, some more characteristic findings. I had a case of this a couple weeks back. What do you guys think? These are not blasts, but what do you think they are? Very large cells.
Quite mega cells.
Right. And what's wrong with these mega cells? Do they look normal to you?
No, they're hypolobated.
Right. They're hypolobated, right? So you have a lot of ugly, very dysplastic megakaryocytes. On the peripheral smear, you'll see giant platelets with very hypogranular. Oh, damn it. All right. Hold on a second.
I love it.
Hey, Lindsay, I'm in the middle of a teaching session. Can I give you a call back after 9? All right, thanks. All right, so on the peripheral smear, hypogranular, large, very ugly looking platelets, very bizarre morphology. So this is probably, you guys probably don't know this one, but does anybody have any clue? Okay, so this is usually associated with patients that come in with on the aspirate smear, you'll see tons of dysplasia. And seeing these big, ugly megakaryocytes is a good indicator of this specific inversion 3 translocation 3-3. Next one, what are you guys seeing here? You got kind of a lot of big, almost blasts with these guys in the background, with very basophilic looking granules in the cytoplasm. And so this one's associated with 6-9. So this session kind of covers all of our, oh, I got a couple more in here. Ooh, man, I'm torturing you guys with these. Okay, what do you guys, what are kind of, what's different here compared to some of the other blasts that we've seen? What do these kind of have characteristic morphology for? Kind of have large blasts. You guys just recently on the blood bank service saw a patient with a 500,000 white count with this kind of morphology.
Is it monocytoid?
Right. So this is a case of predominantly like monoblastic, quote unquote, because you have blasts here and then you have no granules, no R rods, but you have this. Can you guys appreciate this kind of nice folded over, almost like if you took 2 pieces of tissue paper and folded over? This kind of nuclear appearance is very good for monoblastic. Does anybody, this kind of presents more or less in younger age groups, kind of kids, and can also present with DIC and myeloid sarcoma. Does anybody kind of know the translocation involved here? It involves something on chromosome 11.
Ooh, it's not the 911, is it?
Yep. So this is KMT2A with MLLT3. The next one on the right here, you guys see this commonly occurs in kids, usually kids with Down syndrome. And what am I pointing out to you guys here? These are kind of very ugly cells that have these blebby cytoplasmic projections, almost like little pseudopod formation. So what do you think that they, right, right, exactly. So what is the translocation involved in this one? It's a hard one to remember.
Something with 21, I'm assuming.
Close. It's 122. I'll have to look up why the common association with Downs, but anyway, these usually present in very early age groups. So can even present in infants with this translocation. Okay, what is this entity? This is something that kind of can occur in the skin. It's also associated with some other Hemepath malignancies. You have kind of very sheets of blasty looking cells that are classically been described as positive for 1, 2, 3, 4, 5, and 6. Tim, you saw one of these at the NIH.
Yeah, I'm trying not to say anything. Do we have TCL1 here?
I don't think we do.
Okay.
Is it angioimmunoblastic T cell?
No, it's not a bad thought, because you know, I guess what you're seeing here could be some hyalinized vessels, but here as well. But it's so kind of discohesive, and like I said, it's presenting in this. This is actually presenting on the skin. So this is blastic plasmacytoid dendritic cell neoplasm. So this is probably something Cameron Mirza brought it up on his presentation, I think back during one of his review sessions. What are some of the other heme malignancies that this can present in? And just for sake of time, it's CMML, it's MDS, and AML. So
when you say it occurs coincident to these things, like you'll see it as a parallel process, or
yes. And I'm not sure the pathophys behind all that, but when I was in that Hemepath lecture in Florida, that was something that I think I think Fokar discussed this entity, and that's something that she brought up. So this is a 2-year-old male with hypercellular marrow and this peripheral blood smear. So what you're not seeing, you don't see blasts, so I'll just say that. You have these kind of odd looking.
Oh hell, is this the? I've never seen one of these, but is this that juvenile? What is it, JMML?
Yes, yes.
So it's a. I was wondering what is that? Okay, so to answer your question, what are the common mutations? I keep hearing it referred to as a RASopathy, but I don't know what that means.
Right. So you'll see KRAS, NRAS. What are there's 5 that have been listed in the WHO. If anybody has dealt with the patient Mads Pomeranke when they've been on service, this patient has a germline von Recklinghausen, so NF1. And then you also have this PTPN11 as well as CBL, which is associated with Noonan syndrome. So another thing to kind of keep in mind that the common karyotype abnormality is monosomy 7 in these that occurs quite frequently. So just to recap on this one, we have kind of the ugly looking monocytes as well as some neutrophils and whatnot in the background, and you should be seeing dysplasia in these patients because it's one of those overlap myeloproliferative kind of MDS kind of overlap syndromes. So you should be seeing dysplasia, and we don't really need to get into the criteria of how to call this, but just be familiar with some of these findings. So what are the 3 most common mutations found in myeloproliferative neoplasms?
Jack.
Right.
CALR.
Yep.
Yeah, Abel.
Yep.
CALR.
Right. Good. And so looking at this peripheral blood smear on the right, this is classically described as the leukoerythroblastoid picture. You know, you have your blasts, you have your nucleated red blood cells, your teardrops, and occasionally you can see a micromegakaryocyte. So if you had a patient that had this peripheral blood smear with a hemoglobin that's elevated and a low EPO level, what would be your diagnosis? And this is minus the blast.
Oh.
This is just, so it's not a high blast count, so don't
Yeah.
let this mislead you. Say the peripheral blast count's like 1. They just happen. Go ahead.
Yeah.
PV.
Yeah, PV. Good. So what are the 2 significant findings that you see here? And what is the disease process? So first, let's take a look at the megakaryocytes. Do these kind of look normal? What's the morphology?
Are these the cloud-like
Based?
ones? I can't remember.
Yeah, so atypical megs that kind of have this bulbous cloud shape appearance. And another thing to take away, if say this is 40X, should you see 1, 2, 3, 4, 5, like all these megs clustering so close together? And the answer is no. So you guys pointed that out correctly. And then what else? So you see these dilated sinuses. What are they packed with? They're packed with hematopoietic elements. So you have like early granulocytic erythroid precursors as well as some megakaryocytes within these sinuses. So that is a classic abnormal finding that you find in this disease because this is indicative of extramedullary hematopoiesis. And say this patient has a gigantic spleen. So given that these findings, this is a myeloproliferative neoplasm, lots of megs, atypia, extramedullary hematopoiesis occurring in the sinuses. What disease process am I describing?
PV.
Well,
Polycythemia vera.
ET.
this would be actually PMF. So let me go one more. So granted, the findings are sometimes overlap, but I mean, granted, a lot of it's going to come down to morphology, and we never make the diagnosis of essential thrombocytopenia here, ET. I've been told if I ever mention that name again in this fellowship program that I'm not allowed to graduate. So according to Dr. Gerbiksani, it's a very rare and it's almost never really true. So I don't know how much of that is to believe, but the more common things to keep in mind when you're dealing with a myeloproliferative neoplasm are PMF and PV. And if you have increased hemoglobin on a patient, it's in a low EPO level, which I don't know if the boards would give you that much information. It's definitely PV. But if you see this type of morphology with the ugly megakaryocytes with the bulbous cloud-like nuclei and the sinusoidal hematopoiesis, it's likely going to be PMF. So next, this is pretty easy. We have findings from the peripheral blood, a lymph node, and flow cytometry. So what do you guys think those cells are in the top left?
Lymphocytes.
Right, lymphocytes with very kind of hyperchromatic condensed nuclei. Cracked earth, as some like to describe it, soccer ball like chromatin for others. And then this just kind of sheets of small lymphocytes on the lymph nodes. So what is this entity then? Oh, you guys should know this one.
CLL.
Yes, exactly. CLL, SLL. So the things to take away from the flow cytometry is always keep in mind that they are going to have a dim expression of the B cell markers. And they should be positive for CD5, which this is. And then it should lack CD10, which it does. And that's pretty much all I have to say about that one. So just keep in mind CLL or small has 5 letters, CD5, 5. So number 5 with 5 letters, it all fits together. And if the other thing that you can consider in something like this would be a mantle cell lymphoma. However, you could always do a cyclin D1 off the peripheral blood off a cell block or something like that to rule that out. Shoot, I gave you guys some answers. Okay, so we discussed the phenotype. What are some of the prognostic markers and some of the things that we commonly do down here in hematology to whether or not these are going to be a little bit more aggressive than your just normal CLL?
ZAP70.
Right. What are some, okay, so ZAP70, good. There's also another one that's been described as CD49D, which we don't do here. What are some of the prognostic markers that indicate that this may be a more progressive phenotype, something that we can do cytogenetically? So deletion 11q and deletion 17q, I mean, almost always the loss of TP53. If it's ever on a board question and they're asking you what's poor prognostic indicator, you're almost always going to pick this. So I have noticed that this has come up, this question has come up a few times on board review questions, whether or not it's a good marker and whether or not these are poor markers. So this is something likely testable. Moving on, this is flow cytometry, and already some of you are probably already honing in on this aqua blue population, that here is your monocyte gate. They kind of have almost a monocytoid-like appearance in the blood, and then they have this bright expression of 103 25, 11C, and they're B cells, right? Because it's CD19. So if you're seeing this population of cells, what classic heme lymphoid malignancy would give you that phenotype?
Hairy cell leukemia.
Right. So going over hairy cell, should almost always see monocytopenia, right? Splenomegaly, you see diffuse expansion involving the red pulp, right? The red pulp is key, because we'll see in a second. And you commonly, what is all this red? So this is all hemorrhage, right, in the background. And this has all classically been described as red lakes. The phenotype, as we just discussed, everything there along with annexin, cyclin D1 and CD200. These two help phenotypically differentiate some of these other against like splenic marginal zone lymphoma and some of the other low-grade lymphomas that can present in circulation. So can anybody name two other cyclin D1 neoplasms?
Mantle cell.
Mantle
Right.
cell lymphoma.
And there's one more. So plasma cell myeloma can commonly have cyclin D1, and that's because they will, some of the better acting plasma cell myelomas that are a little bit more indolent will have an 11-14 translocation. So that's something to keep in mind, that these three will stain with cyclin D1. And what is the mutation that's commonly seen in hairy cell leukemia?
BRAF.
Excellent. So next, you have these cells in the peripheral circulation. They kind of have almost like a hairy-like appearance, but not really, right? Because hairy cells should have kind of even distribution of projections around the cytoplasm, but these have kind of little stubby, almost little villi-like projections off of them. And then in the spleen, you have this, quote, very targetoid-like appearance, right? And what is this involving here? Is this process involving the white pulp or the red pulp?
Marginal.
Right, it is, so this is splenic marginal zone lymphoma, and something that is very characteristic of this is you see the white pulp expansion. So if you get a slide like this and it shows these almost targetoid-like areas, white pulp expansion, and these cells that kind of look like hairy, but they're not really hairy. They kind of have more of these uneven, kind of stubby little villi. This is all good for splenic marginal zone lymphoma. So just keep these things in mind. They're often, the only things that's usually expressed with these is 20 and 19, and no expression of 5, 10, 23, 103. So that helps kind of differentiate these against hairy cell versus CLL versus follicular. So just keep that in mind. So next, we have a 65-year-old male that presents with hepatosplenomegaly and mildly elevated paraproteinemia. I'm not giving you the paraproteinemia, for at least if it's an IgG versus an A or an M, for a reason. This is the tree-fine biopsy, and you guys can see that it's kind of diffuse interstitial pattern of involvement, which is characteristic. And here we have plasma cells, right? Lots of plasma cells, but what are these cells in the background? They're just lymphocytes. So you have lymphoplasmacytic like appearance on the aspirate. So what's your diagnosis?
LPL.
LPL, right. So let's take that kind of same picture. The patient now has lytic bone lesions, has hypercalcemia. They have this increased IgG paraprotein. now what is the disease process?
MM.
You're right, multiple myeloma. And, you know, just to keep in mind that myeloma, you know, we see so much myeloma here because we're a big center for it, but it will have this very diffuse interstitial pattern too if they're totally packed with myeloma. So good. What are some of the cytogenetic findings that are considered high risk? So once again, we see deletion 17p and then translocation 1416 with the IGH locus as well as 1420. In the prognostic staging system that is used, all three of these are considered high risk disease. And translocation 1114, which is associated with cyclin D1, that's usually an overall favorable prognosis. Which is interesting because we always consider mantle cell myeloma with the same translocation 1114 as a fairly aggressive disease. So moving on to that last question there, Ben, you had already answered this question, was LPL, so lymphoplasmacytic lymphoma. So if patient comes in with, you know, blurred vision and altered mentation, one of the things that I think has been described in the past is Bing-Neal syndrome. So that's also kind of like a buzzword for this type of disease. And commonly you'll see the MYD88 mutation in almost all of LPLs. But just keep in mind that you can have MYD88 in some of the other lymphomas, but given this classic morphologic picture with the IgM and the MYD88, it's always going to be LPL. All right, moving on to this one. We have peripheral involvement by these very deeply clefted lymphocytes. We have this on tissue, and we have these classic findings in the bone marrow tree find biopsy. So given all these three, what's this lymphoma?
Follicular lymphoma.
Follicular, right. So clefted butt, I think these are classically described as butt cells in the peripheral circulation. Tons of follicles all packed together. And classically in the bone marrow, you see paratrabecular nodules. So the translocation involved is 1418, the phenotype here, and just keep in mind that CD10, BCL2, BCL6, LMO2, and HGAL, these are all for follicular center markers. These LMO2 and HGAL commonly aren't discussed as much, but just keep in mind that these represent follicular center origin. And I'll list some variants there. This is just, the rest of these are just going to be all kind of straight morphology. So classic description, say a 16-year-old female that has axillary lymphadenopathy. What are you guys seeing here?
Necrosis.
Right. Lots of necrosis, right? With this kind of almost serpenguous type pattern. You have peripheral palisading of, say, histiocytes, and you have a Werthen-Starry stain. So what disease process is this?
Is that infectious or type of lymphoma?
Not a type of lymphoma, but she has a cat.
So cat
That's
scratch.
disease.
Yes.
Good to know.
Yeah, classically, you always, this is almost like a tarchadoid appearance too, right? So, all right. So moving on with more of the benign lymphadenopathies. This is a 25-year-old female with a tender localized left neck node.
Granuloma.
Is this Kikuchi's? Or?
So right, yeah. So kind of like a granuloma, but what you're not seeing is like good like histiocytes, right?
Mm-hmm.
They're mixed in the background, but they're not forming good aggregates. But this classic appearance here, where you have so much necrotic karyorectic debris without the presence of neutrophils and eosinophils is practically pathognomonic for Kikuchi. But just keep in mind that SLE commonly overlaps with this. So as you sign these out, you might have to be a little bit more descriptive and offer a differential diagnosis between the two and let them figure it out clinically. Obviously, patients with SLE will present with other systemic manifestations, ANA, double-stranded DNA, you know, all those sorts of things. So next, 28-year-old female with cervical lymphadenopathy and Raynaud's phenomenon and the skin rash. So we had just described that there's an overlap. So what do you guys think this is? And what are these? What are these bodies?
Thrombi or fibrin.
It could, but they stain almost. They almost look like calcium deposits on H&E, but they're not, and they're associated along can be associated along vessels. So essentially, what I'm trying to describe is SLE, and these are hematoxylin bodies. So they have very kind of similar picture as Kikuchi Fujimoto, but you will often find these classically described hematoxylin bodies. This is a 31-year-old male with subcutaneous nodules of the left neck. And so what do you guys take away from this one here?
Eosinophil.
Right, lots of eosinophils. And these plump cells here, these are not histiocytes, but these are endothelial cells, right? Because you see the little lumen here. And so you have a proliferation of kind of vessels, lots of eosinophils. And this here is like an old follicle that has been invaded by all these eosinophils. So what disease, benign lymphadenopathy that can present usually in young males, usually describes cervical lymphadenopathy, and they can have elevated IgE serum levels.
Is this Kimura?
Yes, so that was Kimura's, right? So classically described with eosinophilic folliculitis, usually young male, tons of eosinophils, peripheral eosinophilia in the blood, and elevated IgE levels. So this is from a 44-year-old female with posterior right neck lymphadenopathy. And this is like a triad of findings, if that gives you guys any hint. So follicular hyperplasia, monocytoid B cells, epithelioid histiocytes.
Is that viral infection of something?
This patient also has a cat.
Oh.
Yeah, so this is the classic triad described in toxoplasmosis. So this is the toxoplasma triad where you have follicular hyperplasia, monocytoid B cell expansion, and epithelioid histiocytes that kind of ring in the paracortex as well as kind of around these areas of monocytoid B cell expansion. We're kind of running out of time here. So I put in, for you guys, we're going to put this on the M drive so you guys can review it later. But some of the more things, I know this came up on Rise, I think this past year was, they wanted you to make the distinguish nodular lymphocyte predominant versus T-cell rich large B-cell lymphoma. So I just put in a couple slides going over that. Classically, I mean, everybody here pretty much knows the phenotype of Hodgkin's. We see a lot of Hodgkin's here. Off the bat, really quickly, what's this syndrome here?
Sézary or mycosphone.
Right.
Yeah.
Right. So you have the Poitier's microabscess, T-cell infiltrate, and just it helps me remember, going back, that these are memory T cells of the skin. So remember, the T cells, CD4, CD8, come in like 2 different flavors. And the memory cells, usually like, I kind of remember these along the lines of like CD4 helper cells. So these will be CD4 positive. They don't have a cytotoxic phenotype, so they'll be CD8 negative. And they also commonly have loss of CD7. Really quick, the classic triad of findings here with erythroderma of the skin, these cerebriform-like cells in the peripheral circulation, and we have loss of, it would be just commonly described as loss of CD26 in these, as well as loss of CD7. So that's, I put Caesarine here, and I think that covers everything that we wanted to kind of go over. So I'd spend more time on this one, but you guys were running out of time, and we kind of started a little late. So if you guys have any questions, just let us know. Otherwise, we'll try and post this at some point on the M Drive for all of you guys to review.
Thanks, Kyle.
All right.